is given to a strabismus expert who has made a significant impact internationally through education, research, and clinical care. And Dr. Kraft clearly fits the bill there. He was the fifth strabismus specialist to receive this award in the 16-year history of the organization, and the first Canadian to have delivered the keynote address. And of particular note, he's only the second strabismus specialist internationally ever to be awarded both prestigious lectureships. So Dr. Kraft, congratulations on all of your success. You make all of us so proud, and it's a privilege to be one of your residents or your past residents. I've always enjoyed your Monday morning rounds, and I look forward to the rounds this morning.
Well, thanks so much. Thanks for the generous introduction, and appreciate all of the kind messages on ONTI and elsewhere. I just wanted to say that as all of us academics know, this is not an isolated award. I've said that in my message to ONTI, but I've said it to all the colleagues who have emailed me privately, that it's really a group enterprise. These prizes are Canadian accomplishments, and I'll just show you, if you can see that, that's the plaque that's given to the Bielschowsky lecturer, which I display proudly now in my office. And there's also from the World Congress, it's actually a medal. This is the World Congress medal, which I received in Kuala Lumpur in Malaysia in July. So I won't wear it today. It's a little bit heavy. But the ISA award was in Toulouse, France, is where I delivered this lecture. So you'll see there's a little French added here to the title. But this is a reprise basically of the lecture, although I've included a couple of things just in context so you'll understand what this is about. So I hope you enjoy this. As I usually do in my lectures, I include a little bit about art or history, and I've included that here, so you're going to hear the lecture pretty well as I gave it then. So as always, here I'm touting the Canadian flag, of course. I have no financial disclosures or conflicts of interest, but in all my lectures, I do declare a major clinical and historical interest. Just in context, the International Strabismological Association was formed in 1965. Its first meeting was in Germany in 1966. And since that time, they held meetings every 4 years. So it's almost like an Olympics of strabismus. And the meeting traditionally rotates sectors so that you get meetings in North and South America, and then it moves to Asia, then to Europe, Africa. And so they try to cover the different areas of the world. They're now held every 2 years. So in the meeting, we have a meeting, a standalone meeting every 4 years, but in between, there's a meeting held with the European Association, and it's usually held in Europe. So we have combined meetings on those 2 years. And that was the meeting in June. It was a combined meeting between the International Association and the European Association. There's 1,200 members of this association, and the meeting had, there's members in 70 countries, and we had almost that many countries represented actually at each meeting, both the ISA and the World Congress held a month later. And we have an executive council and committees. And the named keynote lecture since 1970 has been the Bielschowsky lecture, and it's awarded, as Amandeep mentioned, to somebody towards the end of their career. So I guess in a way, to receive this award, it means that you're heading toward the twilight of your time in the specialty, but it's something that's very that's quite honorable, and that I list here for you the various lecturers that have given this lecture starting in 1970. Those of you within the strabismus and pediatric ophthalmology spheres will recognize most of these names. Those of you in other specialties and out in the community, some of these names will be known to you because for decades, the Bible, so to speak, of strabismus has been von Noorden and Buren and von Noorden's textbook. Burian unfortunately died in 1970, so he never got to give this lecture, but von Noorden did. He was the first lecturer. And then he found another co-editor of that book, which is Emilio Campos, and you'll see that he is lecturer number 8 along here. Some of these other names will be familiar to you. Bagolini in 1986, he's the fellow that developed the Bagolini lenses used in orthoptic and sensory testing. David Guyton would be familiar to many of you who may have taken the Stanford or Lancaster courses in the United States for early year residents. He's a guru of physiologic optics and gives the optics lectures. He's also one of the top strabismus people in the world. Burton Kushner may be known to many of you. Burton Kushner is the only other one who's given both of these named lectures. Anna Horwood is one of the top orthoptists in the world, the first orthoptist to give this lecture. Joe Deemer has been here in Toronto, very well known, and has rewritten the book on orbital mechanics of strabismus. So these are the lecturers that have given the lecture prior to me, and they are quite the many luminaries in our specialty. Oh, I should just mention that Arthur Jampolsky, the third lecturer, was my mentor. I did my fellowship in San Francisco with him and with the late Alan Scott, who developed Botox. So these names are quite known to many of you. Just a few words historically about Alfred Bielschowsky. He was born in Namslau in the German Republic in 1871. This city is now known as Wrocław, and it's actually in Poland. And his medical career was divided between Germany and the United States. Now, there's no typo here. He actually spent the last couple of years of his tenure in Germany was spent mostly in the United States doing lecture tours, as I'll just mention in a few minutes. And he died in 1940 of complications from a medical procedure. And he was a renowned researcher, lecturer, and clinical innovator. And because he was the top strabismus person in the world during the first half of the last century, it was decided to name the lecture of the ISA in his name. He did his medical training in Germany, and he occupied ophthalmology posts in Leipzig, Marburg, and Breslau. Breslau was probably the top post in the country. And he had some nicknames. If some of you know any German, he was known as the Pope of Strabismus, and was given a nickname Skielbowski, Skiel being the name for squint or strabismus. And these names actually followed him to the United States when he moved there. This map shows you the European landmarks as of the turn of the last century. This is the German Republic here. And he occupied the post. This is where he was born, actually. This is Nemslau, but it's now, as I mentioned, is within the boundaries of Poland. And he was in Leipzig, Marburg, and finally in Breslau was the last post that he held during his time in Germany. He was the head of the department there for 10 years. Of note, during World War I, one of his students, when he was in Marburg, helped him establish a hospital ward with Braille instruction for the treatment of blinded soldiers, which is a model for many organizations, including the CNIB. And he also founded the Association of Blinded Academics of Germany in 1916. And for some of these accomplishments, he was awarded the 2 highest civilian honors by the Emperor William II himself. He was a very popular lecturer, and in 1934, when he made his first US lecture tour, he met Walter Lancaster. Lancaster was a notable ophthalmologist in Boston, and his name is on the Lancaster course and also the Lancaster red-green test, which is another test of ocular motility. And also his award is given for career accomplishments in the American Association of Certified Orthoptists when they want to honor a long-term serving orthoptist in their organization. And this Professor Ames, a very interesting gentleman, he was originally a lawyer, but he went into the area of physiologic optics, and he established what was called the Department of Research in Physiological Optics at the Dartmouth College. It's one of the old August colleges in the United States, which was established actually before the United States was established. located in a small town in New Hampshire. And Ames was the father of this organization, and he invited Bielschowsky to do a tour of the United States. And that occurred in March and April of that year, and he returned to his clinical practice after that, back to Breslau after he finished. This is the map of the eastern part of the United States, just to show you where the institute was located. This is the upper east side of the United States. This is a map of New Hampshire, and you can see that Hanover, where the Dartmouth College is located, is in the eastern part near the border with Vermont. So this is where he was recruited to, quite a change from Breslau in Germany. In the early 1930s, this facility was renamed the Dartmouth Eye Institute, and they decided to create two divisions, a clinical and a research division. And Bielschowsky was invited to head the clinical division, and he returned in 1935 as a visiting professor at the medical school. Unfortunately, while he was in Breslau, Bielschowsky was Catholic. His parents, who were Jewish, had converted to Catholicism, so he was born Catholic. But the Nazis didn't give you any kind of leeway. If you had one relative, great-grandparent, who was Jewish, you were considered of Jewish lineage and were subjected to the deportations and that. So despite the fact that he was a practicing Catholic, he was relieved of his duties as the head of the department in Breslau and eliminated from all editorial posts, and he had to go into private practice. And you could see the writing on the wall. He decided to move to Dartmouth and became a professor of physiologic optics, and in 1937 headed the clinical division of the Dartmouth Eye Institute. Now, he recruited several colleagues. He built up this clinical department, and some of the names that you'll see here will be well known to any people interested in optics and physiological optics, strabismus. So you have names like Ogle, names like Boder and Links. Arthur Links, I'm going to mention a little bit later. He was an ophthalmologist, an expert in optics, and also an expert in art history. I mentioned that Bielschowsky was in high demand as a teacher, and his students in the clinical division included Hermann Burian and Walter Lancaster, these two names that I mentioned before. Burian actually was David Smith's mentor. Dave Smith did his fellowship with Burian. So in a sense, Dave Smith, our own Dave Smith, is a grand fellow of Alfred Bielschowsky. So, you know, we have grand fellows now from the time that I've been here, but this is interesting. We have this lineage from Bielschowsky through Burian to our own Dave Smith. These are just photos from the time that Bielschowsky was spending in Dartmouth. And this is his legacy. This was the growth of the department. This is the Dartmouth Eye Institute, all of the members, and very notable that there were many women members during that time. He was quite enlightened, and he left this legacy. Unfortunately, he died in 1940 in January, so this picture unfortunately does not have a picture including Bielschowsky. But there's various people here. Burian is here, Links is here, and Lancaster as well. What I'm going to spend the rest of the time is based on the lectures in motor anomalies. This was a textbook that was produced after his death, based on the lectures that he used to give when he did his lecture tours in Europe and in North America. It was in 12 chapters and based on some lectures that he did in 1938 in Los Angeles to the Research Study Club there. And it was originally published because they were so popular. The American Journal of Ophthalmology agreed to publish his 12 chapters, one each month between August of 38 and July of 1939. And then the Dartmouth Medical School published them all together in a textbook, and they were given permission to do this by the editors and publishers of the American Journal. And his goal was to upgrade the knowledge base of American ophthalmologists and strabismus. And actually of interest, he actually found that in Germany, there was a lot of knowledge base that was really quite poor in strabismus and wanted to upgrade it there as well. So he found the same problem in the United States and went around trying to upgrade their knowledge base. So the lecture I prepared is what is still current that he mentioned in his book and what has changed. And since I gave this lecture in France, I thought that the theme of what is new and what is current and what has been learned over the years, there's no better example than this painting, arguably one of the most famous paintings in the world, located in Paris at the Louvre. And this is the Mona Lisa, which is actually known in Italy as La Gioconda, which was painted by Leonardo da Vinci in the early 1500s. And for 1,500 years, this enigmatic face has been staring at us from the walls of various institutions and for many years now in the Louvre. And the question is, whose face is actually on this painting? Originally, it was thought it was actually the wife of the person who commissioned Da Vinci to paint it. That's Francesco del Giocondo in Florence, Italy. This is thought to be the painting of his wife, but it actually is not. There was another very famous Duchess of Aragon. It was thought perhaps it was hers, or there was some theories that this may have been a secret male lover of Da Vinci. Innovations in the 20th century, including X-ray crystallography, infrared photography, and computer art and graphics since the 1980s, have actually given us clues as to who this person actually is. And with these developments of these various modalities, we found that at one of the times that Da Vinci's painting was being restored, that there were actually hidden etchings from his original pencil marks, which he did on the canvas. So the masters in the Middle Ages used to etch in the original on the canvas and then paint over it within the lines. And you could see here that when they did the infrared crystallography or the infrared recordings and the X-ray crystallography, that in fact the etchings on the canvas you can see on the right do not match the face or the actual upper part of the torso here. The lower part does match, but not the face or the head. So the question is, whose face is it? I'll give you the answer a little bit later. So here is the set of things that I wanted to discuss with you. Just some points from his book about the etiology of strabismus, diagnostic, sensory, and motor testing, various clinical forms of strabismus, and also the treatment. So talking about the etiology, there are some new concepts in strabismus that have been addressed over the last decades. Bielschowsky, in his book, and I'm giving you the reference of the pages in that book, classified strabismus into innervational, mechanical, and combination of both. And all of you that have been through my hands as residents will know that for incomitant strabismus, this is the paradigm that we use for innervational mechanical causes with various differential diagnosis of each. And this actually comes from the teachings of Bielschowsky 100 years ago. But he suggested that there was a fourth factor, this mysterious, what he called excess or spastic motor innervation that may be at play, because you couldn't explain all of strabismus under these three categories. And he considered it a contracture of a group of muscles with a gradual change in muscle structure. This has been, in the last number of years, been elaborated as sort of a baseline innervation of extraocular muscles, which we call vergence tonus. And these have been elaborated by people like Schiavi and, again, the David Guyton, who have called this unguided vergence tonus, which changes the lengths of the extraocular muscles and is responsible for changes in the angle of strabismus over time. And there's actually been symposia. This is a symposium from the Smith-Kettlewell Institute held in 2006, a full weekend solely on the subject of extraocular muscle tonus. And within the proceedings of that meeting, Michael Brodsky, somebody else known to all of us, very prominent strabismologist and neuro-ophthalmologist, gave the definition of tonus as the innervational component of muscle tension due to baseline neural input. And it refers to the state of muscle contraction from sustained involuntary CNS innervation. And this is the tonus of the extraocular muscles that can explain some forms of strabismus that can't be categorized under just innervational or mechanical causes. Annette Spielman, a prominent strabismologist from France in the mid-1980s, developed testing which was used clinically, and we still use these translucent occluders, which we have in our clinics here at Sick Kids, were developed by her to allow us to view the eye muscle alignment through these occluders to try and dissociate the static free position to eliminate some of the factors leading to the alignment, including the tonus of the extraocular muscles. So we use these translucent occluders to try and get at the basic deviation. And one of our colleagues in Toulouse, Dominique Touvenin, a Canadian who moved to France, he actually uses this principle when he decides on surgery dosages, depending on the findings under anesthetic and depending on what the alignment is under general anesthesia, relieving the tonus of the extraocular muscles, he actually changes the type of surgery that he will do. So that is this tonus is still a concept that's being developed in recent years. Another is the effect of prolonged occlusion testing. As those of you that have trained with us will know, we have a standard test for patients, for instance, with intermittent strabismus, whereby we occlude the eyes for a period up to an hour to try and dissociate the eyes to get at the basic deviation. Back in Bielschowsky's time, and he himself practiced what was called the Marlowe technique, where they would occlude the non-dominant eye for a week and sometimes occlude the dominant eye for 1 week, feeling that the relief of this tonus would require prolonged occlusion for many days. Over the years, we've learned that we can get at the same information with a much shorter interval, and we currently use the standard of 1 hour, which was used by Burton Kushner in his papers where he dissociated the patients with exotropia for up to 60 minutes to measure the total phoria and tropia. And this is the standard that we use now, not the 1 week that was touted by Bielschowsky. There was also a concept of what we called active divergence, and this has been a controversy that has raged for several years, several decades actually, in the strabismus literature. Bielschowsky postulated near the end of his book that he felt that there was something called active divergence, which could cause the eyes to gradually diverge more and more over time. And he thought that there was a supranuclear control center for it, and he thought it was actually near the abducens nucleus. The concept of active divergence has been disputed by luminaries such as Jampolsky and Richard Scobie. Richard Scobie is actually the person for whom the orthoptic named lecture that's given at the American Academy bears his name. But he was a prominent strabismologist in the US in the 1940s, and they both argued that there was not any active divergence, but it was simply the release of elastic forces of convergence. However, other luminaries, Goodwin Brynan and Alan Scott, the famous Alan Scott who developed Botox, these two gentlemen spent a lot of time doing ocular EMGs in the 1950s, 60s, and 70s when they were in vogue. And this is an EMG recording of a simultaneous recording of multiple extraocular muscles. And Alan Scott claimed that he could see from these EMGs that in certain types of exotropia, there was actually active divergence on EMG, confirming that there may be a divergent center. However, it's still controversial, and the exact position of where this might be is still not known. Moving on to sensory testing. We're going to talk about after-image testing, double Maddox rods, and fields of binocular single vision. After-image testing was Bielschowsky's favorite test. He spent many pages in his book and a large portion of his lectures talking about doing testing for sensory correspondence. And he enjoyed the after-image testing. That was his go-to test. And his position was that you wanted to determine whether a patient had NRC or ARC prior to surgery. And this is how the test is done. It's done by imprinting a horizontal after image in one eye, a vertical after image in the other eye, and asking the patients what do they see. And on the right, you can see the responses are normal correspondence on the left and abnormal correspondence, either of the results on the right. And his claim was that if you had a normal response preoperatively, that you had a good chance of restoring binocular single vision. If you had ARC, there was a high chance of paradoxic diplopia, and it may actually lead to fusion disruption. So it was very interesting that at the end of all of this text, he actually wrote that when all the tests are considered, there were still patients who had ARC on this testing who still got the highest degree of binocular vision after surgery. So he actually wrote that he wondered if the practical purposes of taking the trouble to do it was actually worth it. So it's quite interesting that at the end of all of this mental gesticulations, he didn't actually feel that maybe the test gave you the information that you needed. So we use various other tests. The test after image is actually what we call a fovea to fovea test. The tests that we do most commonly now are what we call fovea to periphery tests. The one that you're all familiar with, the Titmus stereo test, Bagolini lenses, Worth 4-dot. We find that these are maybe more predictive of how the patient's sensory status is going, and the synoptophore on the left, which can do both fovea to fovea or fovea to periphery tests, can actually confirm these. So this is where most orthoptists are right now. After image tests are usually used in research protocols, very rarely now in the clinical sphere. Now, what about double Maddox rods and superior oblique palsy? When I was a resident, our local guru, Ray Bunsick, taught me and taught many residents this test, which actually goes back to Bielschowsky. If you have, for instance, a right fourth nerve palsy, which generates a right hypertropia and extorsion, if you ask what is the subjective response by the patient, if the Maddox rod is right on the left, on the right eye, and the clear on the left eye, the subjective response of the patient is a horizontal line in the normal eye, but the right superior oblique palsy will generate an image that is intorted and lower. So we're talking about the patient's subjective response. So this is what the patient sees on their right and left is a horizontal right image that is white and a red image that is intorted and down below. And if you have the right eye affected and you just enlarge this and shade this in, it's actually an arrow. It's an arrowhead that points to the eye at fault. So this little handy clinical pearl that I was taught by Ray Bunsick as a resident was actually first described by Bielschowsky in his book 50 years earlier. So it's a very handy little pearl, and it actually can be used to dictate which eye is the eye that has the palsy. Now, the dynamic field of binocular single vision is something that we do quite often here. And we actually wrote several papers here at Sick Kids from some of the orthoptists that I have had the pleasure of working with here. But the original person who described binocular visual fields was actually Bielschowsky. And this is a case of a right inferior oblique palsy where he actually plotted out the area of single vision and the area where the patient had vertical diplopia going from right to left. And so he was the first that I found actually used these in his evaluation of paretic strabismus. Currently, this is the method that we use here in Toronto, which we described many years ago. The co-author was one of our former fellows, Tim Sullivan, and the orthoptist involved was Carol O'Reilly, who many of you will know from the past. And we use the Goldman perimeter, which we have preserved here in our department, and we've changed the fixation here to the target to a plus sign, which actually allows us to do both fusion testing for horizontal, vertical, and torsional diplopia. And we plot the binocular visual field in the various meridians. And we have a scoring system which we developed, which is a weighted scoring system with most of the scoring points. There's 100 points on the scoring grid, most of it concentrated in the middle 30 degrees and into down gaze. And we can use this to do quantitative weighted scoring systems of the field of binocular single vision. So the template fits on the Goldman plot. And if we have a patient, for instance, with a left fourth nerve palsy who has diplopia in right gaze and down gaze with a weighted score of 56%, you can now show when he's post-op that we've improved it, and now the score is at 90%. And so we have these weighted scores where you can show patients improving between pre-op and post-op results. And this is now a weighted scoring system that can use for medical legal evaluation, insurance evaluations, and so on. And so we've taken this several degrees beyond what Bielschowsky described. What about motor testing? The various devices that were developed at the Dartmouth Eye Institute, including what was called the Riley Prism, which I'll mention in a minute, and also the head tilt test of Nagel Bielschowsky. Bielschowsky was an innovator. Not only was he a superb lecturer and clinician, but he developed several devices, one of which is called a haploscopic device. Now, these are both clinical and research tools where you dissociate the image between the two eyes and then examine the strabismus that results. And there are very sophisticated devices now. This is a diagram of one of the devices that's been developed in recent years. But what Bielschowsky developed with these haploscopic devices is this calibrated grid. And within his devices, you could actually measure to the degree the strabismus and phoria that has developed. And he developed a device called the heterophorometer, which is really a dicoptic device. And this is the diagram in his book where you can see this device. It's a haploscopic device that actually has that measurement grid on the screen. And with that, he could measure the device. The device actually allowed him to measure the total phoria and tropia, both vertically and horizontally, and also with some torsion measurement as well. Now, the rotary prism, now this is a prism also called the Riley prism, and it's used to measure fusional amplitudes. This device is now incorporated into 4-opters, and it's actually 2 prisms abutting one against the other, and by rotating it, you can measure both horizontal and vertical tropias and phorias. On the left are the 4-opters that existed 100 years ago during Bielschowsky's time. On the right is the more common 4-opter that the residents and our trainees and clinicians will be familiar with. And you can see that built in are these devices, which are the Riley prisms, which allow you to measure horizontal and vertical phorias. And so the prototype is actually based on the research that Bielschowsky had done 100 years ago. Now, what about the head tilt test? The head tilt test that we call the Bielschowsky head tilt test is really wrongly named because 30 years earlier, an ophthalmologist by the name of Nagel described the head tilt test in 1871. And this is the reference you can see in the German literature. And what it is, it's the tilt test that actually diagnoses vertical muscle palsies. So you can see on tilt to the right, this young man develops a right hypertropia, which disappears on head tilt to the left. Bielschowsky noted that a positive tilt was found only in an imbalance of the oblique muscles of the eye. And he didn't feel that it was of use in vertical rectus muscles. Now, this goes against what I've actually taught our residents because their 3-step test, so to speak, is supposed to be valid for any of the 4 vertical muscles. Bielschowsky felt that the head tilt test was only valid for oblique muscle problems. And in 2002, Van Noorden and Campos, who were the co-authors of the Bible of Strabismus, the book on binocular vision and ocular motility, they felt that the 3-step test, which Parks had described, could distinguish a paretic, oblique, or vertical muscle palsy. So by the time these textbooks were being published in the various editions, they felt that actually it could diagnose a vertical muscle palsy. Bielschowsky found that in several hundred cases of oblique muscle palsies that it was always a positive, almost pathognomonic result to actually find a positive head tilt difference. But we know in 2024 that he was not correct. For instance, in 1986, in a paper on superior oblique palsy by von Noorden, he found that the test was only positive in 75 to 80% of cases. We also know from the work of Joe Deemer and his group in Los Angeles that there are conditions that mimic superior oblique palsy, which include positive head tilt tests, when in fact there is no superior oblique palsy that is present. And he showed MRIs. You can see the MRI on the left, where you have a documented small paretic superior oblique versus a normal one on the other side, and a case in the bottom there where the superior obliques are radiologically and innervationally normal, that these patients both had the same positive head tilt test. And in a large group of patients, you can see on the left, patients with superior oblique palsy who indeed had larger hypertropias on tilt to the ipsilateral side, as compared to the patients who did not have superior oblique palsies. And you can see on the right that they had the exact same distribution of head tilt test positivity and numbers in their prism diopters on tilt to the right and to the left. So the head tilt test of Nagel-Bielschowsky, while it can confirm a superior oblique palsy, first of all, it doesn't occur in all cases, and secondly, is not pathognomonic for a superior oblique palsy. So you have to look clinically for other signs of the superior oblique palsy, specifically under or overaction of the oblique muscles. What about various clinical forms of strabismus? Bielschowsky's name is very linked to the diagnosis and clinical features of DVD. And also we talk about divergent paralysis and V shifts. As far as DVD, Bielschowsky in his book and in his papers called the term alternating hyperphoria or dissociated hyperphoria, which is a name that is used by several clinicians, especially in Europe. And he felt that it was not based on an anomalous position of rest, that it was simply an elastic force of the vertical muscles, but that was due to an innervational cause, the origin of which is not known to us at the time. So this is 100 years ago. But over the years, we've had developments in technology, such as the eye tracking, the eye movement recording devices that have allowed accurate recording of eye movements. And here is a case of dissociated vertical deviation, which we recorded here in the lab of the late Marty Steinbach, whom we remember with reverence and with love. And he and his team recorded patients of mine with dissociated vertical deviation. And you can see that it is an interesting recording when you expand it, that there are these little artifacts of little nystagmoid movements on the vertical recording of these dissociated vertical patients. And David Guyton, 25 years ago, felt that DVD with these, he also recorded patients and showed that these little blips may actually be latent nystagmus, but it could be vertical latent nystagmus, and they may actually help to dampen the DVD. And the DVD is actually, DVD is a method of trying to dampen a cyclovertical component of latent nystagmus. Michael Brodsky, around the same time, actually felt DVD was an unleashing of a primitive visual vestibular reflex that you see in fish and in lower forms that is actually suppressed in fully binocular humans. And that DVD is kept latent by normal binocular development. Others around the same time show that it's an induced vertical vergence with extorsion that may actually point to the fact that DVD may be part of a dissociated torsional deviation. And finally, in 2009, our colleague Ed Wilson in South Carolina actually published evidence that dissociated vertical deviation is part of a much more complicated dissociated complex that includes vertical, horizontal, and torsional deviations with latent nystagmus. And this is also, he agreed, it's a resurgence of a dorsal light reflex present in lower forms of animals and fish, and it's unleashed when patients do not have normal binocular vision from birth. So this is where we are at right now. So we feel that it is a dissociated complex, which is an unleashed light reflex phenomenon, and is a part of a much more complicated phenomenon. And Bielschowsky described what's called the Bielschowsky phenomenon, dissociated vertical deviation, where if you put a progressively darkening lens over the fixating eye, you actually can see the dissociated vertical reduce until the eye actually comes to the horizontal plane, just confirming that there is a light-induced situation that is causing this phenomenon. Bielschowsky actually described a very rare form of this, which is a dissociated hypotropic deviation. So you can actually see that there are cases of dissociated vertical deviation where the eye actually goes down and not up. And we've recorded patients like this. Again, our group with Marty Steinbach and his associates, Beth Irving, and one of our fellows, Boon Long Hua, and also one of our former fellows, Hyun Tak Lim in Korea, who have described this condition where we actually have a dissociated vertical deviation that is downward. And it is not the same, just for our neuro-ophthalmology colleagues, this is not the same as a Bielschowsky phenomenon, or what we see the Hyman-Bielschowsky phenomenon described in poorly seeing eyes. The time course and recording of a DHD hypo-D is actually different from that of the Hyman-Bielschowsky phenomenon. So this is a unique, very rare form of dissociated vertical deviation, which was actually originally described by Bielschowsky. What about divergence paralysis? He described this condition in his book as a patient who has diplopia with esotropia only at distance. And it's comitant, right to left, and can be regained. The fusion can be regained at distance with a base-out prism, and it's specifically characterized by a normal deviation or minimal deviation at near. And he assumed that most of these cases were due to latent, probably sixth nerve palsies, and patients that had had this for so long that they lost the features of the sixth nerve palsy, or it may be that it's a latent esophoria that has decompensated. But we now know, in the last few decades, progress in the area has shown that many of these cases are actually not pure divergence paralysis or, in fact, sixth nerve palsies, but rather one of two conditions that have now been well described, one called the sagging eye syndrome and one called the heavy eye syndrome. The heavy eye syndrome has now been well described. This is in patients with highly myopic and enlarged globes, where you can see that the array of the ocular muscles has been displaced such that the lateral rectus muscle is no longer an abductor. And in these cases, what you have to do is to surgically reunite the superior and lateral rectus muscles, a procedure called the Yokoyama procedure. Yokoyama, one of our colleagues in Japan, was actually a previous Bielschowsky lecturer, and his lecture contains all the details from his research on this condition. In addition, there is a condition known as the sagging eye syndrome, where a patient has an esotropia that is worse on side gaze, and characteristically, the eye actually depresses on side gaze. And these patients have a rupture of the band, the intermuscular band that connects the lateral and superior rectus muscles. And you can see the lateral rectus sagging below the horizontal, and this causes an esotropia in distance, but it actually does not change the alignment at near. And in these cases, the procedure that we do is to realign the lateral rectus and bring it back into the horizontal plane. And that can solve the deviation at distance without corrupting the deviation at near. A short word about V-shifts. We know that there's a change in some patients. Their alignment changes from up gaze to down gazes. But Bielschowsky noted, and he was a very keen observer, that it's actually physiologic to have a small V-shift in normal patients. And he felt that this was due to a mechanical orbital conditions that favored a divergence in up gaze and convergence in down gaze. Shortly after his death, there was more literature that came out of South America, where Uritz Zevelia described the importance of checking up and down gaze measurements because this was a very frequent phenomenon. And the A and V syndromes were described in more detail by Urist in 1958 and confirmed again by Stewart and Burian in 1962, who confirmed Bielschowsky's claim that divergence is normal in up gaze and some convergence in down gaze, and these are physiologic. So therefore, as we teach the residents, the criteria for a V pattern is 15 prism diopters between up and down, but only 10 for an A pattern, because we expect some V shift is normal in patients. The final section I'm going to talk about are various aspects of treatment of strabismus from things that Bielschowsky had written: adjustable sutures, Duane syndrome, horizontal and vertical corrections, and transposition surgery. Bielschowsky was the first clinician to describe adjustable suture surgery. So the use of adjustable sutures goes back to 1907, over 100 years ago. Bielschowsky described that in his book and in his papers going back to very, very early in his career. And he was an innovator and used it for any of the ocular rectus muscles. He used it frequently in his surgical cases. What was interesting is that he would put his adjustable stitches into the conjunctiva near the corneal margin rather than into sclera. And he would do his adjustments either the following day or 2 days later until the swelling and discomfort settled in his patients. This was abandoned by most clinicians for several decades until Arthur Jampolsky, who was one of the mentors with whom I studied in my fellowship in the 1980s, he revived its use as a routine adjunct to surgery and was a proponent of this for several decades. And it was used again as his routine adjunct to surgery. And those of us that studied with Jampolsky have used these techniques for many years. One of the controversies that has raged is, does it really increase the success of strabismus surgery? And this has been a raging controversy in the literature for many years. There's a lot of literature that suggests that using them as a routine does increase our success of strabismus surgery. And you'll notice that 2 of the papers that are positive for using adjustable sutures is work that's come out of here in our center, led by my good colleague, Hamiar Miras-Kandari, in a couple of very large studies. There are a couple of papers on the other side that say there's no difference whether or not you use them, but it seems that the seesaw is tipping towards the fact that it probably is helpful. The American Academy came out in 2022 with a statement that it seems to have an advantage, but is not uniform among studies, which just reiterates what I'm showing you here. So if you look at the success according to the alignment, Hamiar's study that we did together now almost 10 years ago shows that if you can achieve the target angle at surgery, that the success actually improves by up to 20%, and that using adjustable sutures, the arguments we make is that you can achieve the target angle much more often, and thereby its nature can improve the success. If you use criteria of reoperation rates, you can actually show a 30% decrease in the need for reoperations if you use an adjustable suture. And in children, a study 5 years ago from Baltimore showed that when they tested children in the postoperative area, that they actually had to adjust them in 32%. That's a little bit higher than what I think we need when I look at my experience, but it shows that these studies show that there is an increase in success. And so it does justify what Bielschowsky said when he used it routinely in his patients. In Duane syndrome, among the many features of Duane syndrome, Bielschowsky noted that at surgery, he often found this non-elastic fibrous band that was not a muscle, but replaced the lateral rectus, which didn't allow the eye to relax and contract on adduction, and that it contributed to the retraction phenomenon. These elastic bands and anomalous structures in the orbit have been described by many people in the last couple of decades, including a colleague of ours in Turkey, who found up to 32% of patients with esotropic Duanes had these anomalous bands. You can see it here on the right. This is a patient of mine. You can see when this patient is in primary position that there's an indentation of the globe. And on the bottom photo, you can see how much it indents the globe on forced adduction. And these have to be cleared very carefully from the sclera if you're going to relieve the retraction and the abduction limitations. What about combined horizontal and vertical strabismus? Bielschowsky actually mentioned casually in one of his surgical chapters that if he was doing horizontal muscle surgery and there was a small vertical deviation, that you could actually offset the muscle simultaneously to correct both problems at the same time. This is a little handy surgical pearl that I've been using since I started practice, and it was taught to me by Henry Metz, a colleague who used to be, he was originally the editor of the Journal of Pediatric Ophthalmology and Strabismus, but he was a Jampolsky fellow, as I was, and he actually took this concept many years later and developed a dosage table, which you can see from his papers on the right here, where you can actually do a dosage response table when you offset the horizontal muscles vertically. How many diopters can you correct per millimeter of offset? And it turns out it's fairly linear and is almost a diopter per millimeter. And so Bielschowsky simply touted it as one of his tools in his surgery. Henry Metz took it one step and showed the actual dose response curve. Finally, transposition surgery for 6 nerve palsy, one of the most interesting changes that we've seen in treatment over many years. Bielschowsky used what was called the Hummelsheim procedure, where you take half of the vertical rectus muscles and transpose them temporally. He described these as far back as 1907 with a colleague that he knew personally, which was Ernst Hummelsheim. But he didn't like that procedure because he didn't think that it induced enough correction, as opposed to simple horizontal recess and resects. And that's what he did in his treatment of 6 nerve palsies. He would do large recessions and advancements, or recessions and resections in order to straighten these patients. But over the years, these are just some of the many different innovative ways that people have used to transpose muscles. The Hummelsheim variant is the one at the top left, where you take half of the muscle and move it over. And I've used this for mild 6 nerve palsies, or also, in fact, for Duane syndromes. We described an alternative here in the top right, one of our fellows from Mexico. This is a procedure where you transpose the muscles and resect at the same time. And this is actually the most powerful transposition procedure on its own. In the middle there on the right, you can see what's called the Foster transposition procedure. And other colleagues have shown in the last 15 to 20 years that you can actually transpose just one vertical rectus muscle with a myopexy suture and treats some of these conditions. The procedure that I use now is not the one that I mentioned before, but is a procedure called the Nishida operation, which was described in Japan about 20 years ago, where you simply transpose part of the muscle without detaching the muscle, and you transpose the lateral border of the superior and inferior rectus muscles over towards the lateral rectus. This turns out to be a very powerful operation. And some people have called this the modified Nishida. It's not. This is actually the original Nishida described by the surgeon himself. And so this is what my go-to operation is now, often with a medial rectus recession. So this has been a tour through Bielschowsky's textbook, some of the things that I found interesting. And there's many more pearls that he has, which maybe I could put another lecture together sometime in the future. And this is the essence of the lecture that I gave, what is current, what has changed. And perhaps in another 100 years, there'll be 50 Bielschowsky lecturers from now. Maybe the 66th Bielschowsky lecturer will look back at the next 100 years and tell us where we've taken the specialty from now through till then. Hopefully my colleagues out there in the community on cyberspace here will see that we're just like the glaucoma and cornea and retina people, that a lot has progressed in our specialty as well. And it's been a fun specialty for me throughout my career. And now I'd like to thank all the people who have been, my allies, the 240 or so residents, the 170 plus fellows, all my colleagues here, the terrific chiefs we've had here at this hospital, at the university, and the supportive environment we've had, the orthoptists I've worked with, the vision scientists. So the awards that you get for these kind of academic achievements are not my own. They're there with the community and environment. And so I think we can all take pride from our local community when we get these awards. And we've had many of our colleagues out there have gotten national, international awards. So this is just one more of many accomplishments of Canadian and local Toronto ophthalmologists, and we should congratulate all of them as well. So going back, I talked about innovations. This is the enigma that's faced people for 500 years. Who is that face on the Mona Lisa? Well, it turns out that there are two existing self-portraits that Da Vinci did. This is the one that is most famous. And the modern computer and various crystallography and so on have shown that if you match up this self-portrait to the face on the Mona Lisa, that it actually matches 99.8% accurate. And that's all by computer simulation and by the techniques that I mentioned earlier on. And here are some of the references to that. Arthur Lynx, who was one of the physiologists and ophthalmologists that Bielschowsky had recruited to the Dartmouth Eye Institute, wrote a book called The Ophthalmologist Looks at Art. And there is actually a Lynx Award, which is given by the International Strabismus Association. So while I gave the Bielschowsky lecture, Derek Sprunger, a colleague of ours in Indiana, was given the Lynx Award, which is given at each of those meetings as well. And it's a medal, and that medal is named for Arthur Lynx. And one of the prizes that you get with the Lynx medal is the actual original book by Lynx. And Lynx makes the point in his chapter on the Middle Ages that the artists, the painters, Rembrandt and Van Meer and all of the famous artists and painters of the Middle Ages usually had a mirror beside the canvas. And that's how they did their self-portraits. And so it's thought from this information and from modern science now that the face on the Mona Lisa is actually the face that Da Vinci saw in the mirror that stood beside the canvas. So I put in the thank you there to as many of the thank yous as I could that could fit into that space. These represent the most common languages that are in the world today. And if any of my peers can actually, you get a prize if you can tell me what the 3 thank yous are at the bottom. Give you a bottle of wine, anybody that knows what those are. It's actually, pardon?
Indigenous.
No, it's not indigenous. I should put an indigenous one as well, the next lecture. That is the thank you in Klingon, Romulan, and Vulcan. So Lesek Shaya Tonat to everybody out there, and that's the lecture. Thank you.
Awesome, Steve. Thank you so much. Just one quick thought. I think if that's what he saw in the mirror, he must have had some beer goggles back in those days. You know, they didn't drink a lot of water. It was all beer and wine, and that kind of explains the difference between his image and his and what he saw in the mirror. There is a great lecture, though. There is a question from Tom Wright. I've unmuted him. Tom, are you there?
Sorry, I am here. No question here. Sorry.
Okay, no problem. Peter, do I see you talking? Yeah, go ahead.
Yes, sorry. What a great whirlwind tour of strabismus, Steve. Congratulations on your prize. Your prizes and medals, and they're well deserved. You're a real credit to our department.
Well, thanks so much, Peter. I just, for those of you out in cyberspace and here, the lecture that I gave in Kuala Lumpur was actually entitled Tips and Pearls from 42 Years in Practice. And I've got the honor of giving that talk at the Jack Crawford Day in 2025, which will be April the 4th. So those of you that will be attending that, I'll be giving the essence of that talk there. So since most of my colleagues couldn't make it to Kuala Lumpur, you'll have the chance to hear that lecture in a few months from now. So again, thanks to the UofT community for giving me the chance to be able to do what I do and to be able to get the accolades on behalf of the team and the environment and Canadian ophthalmology here. So you congratulate, pat each other, pat everybody, should pat each other on the back, because this is a team award. It's a Canadian award, not just mine individually.
You're too modest, Dr. Kraft. You deserve all the accolades that are coming your way. And personally, I as a former resident and now colleague of yours, I'm so proud to see your accomplishments. And we do have David Smith with a comment as well. Dr. Smith, go ahead.
Well, Steve, I think it's just a terrific presentation that we've been talking. I think about a year ago, I went through some of the history books too in strabismus, and that was kind of fun to see what people were looking at many years, hundreds of years ago, about trying to fix eyes, make them straighter. But this is like a stellar lecture, and I want to thank you so much for giving it to us.
Well, thank you, and I was able to. I was glad to incorporate you and Ray and a whole bunch of other people into the mix, and names of people like Marty Steinbach and many of our colleagues who we remember with reverence. It was nice to be able to bring them into the fold as well. And so you're a great you're a grand fellow of Bielschowsky, so it's nice to have the legacy with you in person.
The only thing I might mention is that I know a lot of people like to make vision better by putting lenses in and fixing cataracts, but there's no point in fixing the sight if you don't have nice straight eyes. So I'm thinking that strabismus still is a pretty important area and lots of fun, frankly. Lots of fun. So.
Absolutely. There's no, from a cataract surgeon, no argument to that, Dr. Smith. I totally agree. So we will wrap it up. We're a couple minutes over. I do want to thank Dr. Kraft and the entire team at Sick Kids for their collaboration this morning. And I will plug that next week's rounds are special Jeopardy rounds that Dr. Edsel Ng has put together. So I think it'll be great. I'm sure there'll be some historical tidbits in there as well, but also some Q&A, which will be good for the residents as they prepare for their exams. So Dr. Ng, we look forward to your talk next week. Have a good weekend, everyone. Bye.